આપણું હમણાં બેના ડોકા દેખાય બસ જો
Okay, good morning, friends. Welcome back to Saturday Club morning meeting. And today we have a very interesting topic: journey of bone marrow transplant at Kailas Cancer Hospital and Research Center at Goraj. Incidentally, I happened to visit this institute few days back for conducting young adults session on mental health. They have a nursing college there, and we address about 100 students there. That time I was fortunate to have Dr. Rajesh Kantharia and Dr. Sainaz to take me around the whole setup, and very impressive setup. I mean, this Goraj hospital is very well known for many years, but now it has expanded its services and facilities to a great extent. And one of them is this bone marrow transplant facility that has been started there. And to talk to us about their journey of bone marrow transplant, we have with us Dr. Shailesh Lavana. He is a very young hematologist, got his DM clinical hematology from CMC Vellore in the year 2017. He was ex-team stem cell transplant physician at Sankalp India Foundation, and currently he is hematologist and stem cell transplant physician at Kailas Cancer Hospital and Research Center, Goraj. To his credit, at a young age, he has several publications to his credit. And important thing was that when he was working at CMC Vellore, he received an appreciation award for outstanding service at his center. So with this brief introduction, I request Dr. Shailesh Lavana to tell us about his journey of bone marrow transplant at Goraj. Thank you, Shailesh bhai, for accepting our invitation. Now the stage is yours for next 45 minutes or so, and we'll have some 10 minutes of discussion. So over to you.
Thank you, sir. Can you hear me, sir, now clearly?
Yes, we are able to hear you well. We are able to see your slide also. Please go ahead.
First of all, I would like to thank you, Dr. Satish sir, to giving me an opportunity to show my work actually. And today I will be presenting about the bone marrow transplant. I'll be presenting in like three. First, I will tell about the magic of the transplants, especially in the thalassemia patients. Then little bit about the overview, what is the stem cell transplant, how it is done, and the type of the transplant. And third part, I'll be covering that how we started the bone marrow transplant and where we have reached. So first of all, you can see slides actually. There are two photographs. The first photograph, a person when he was in stem cell transplant unit, and the second photograph is that is his photograph just 6 months before. I encountered this person. He's a Guju fellow, and I met him 2 years before actually when I was working in the Sankalp India Foundation. He was a patient with the thalassemia major. Now those pediatricians actually very they will knowing that what is a thalassemia major. I will just briefly about the thalassemia major. The patient who is suffering from the thalassemia major, they require the blood transfusion to survive since their childhood. And this fellow, the birth that you will see the 1st July 1983, and when he was 14-year-old, he went to the CMC Vellore, and that he got transplanted. And the next month, he is going to complete the 25 years of his life after the transplant. It means when before the 14 years of his age, he was the transfusion dependent, and he was requiring the transfusion every 15 to 20 days. And after the transplant, he never get transfused. It means we can say that before the transplant, his family was spending the money for his treatment, and once the transplant is done, now he's earning money for his family. So we can say this is the truly the magic of the stem cell transplant. And in the thalassemia, the stem cell transplant, the success rate is very, very, very good actually. When the patients, if they are getting transplanted below the 7 years of the age, the success rate is almost 90% with the match-related donor transplant. Now I will tell about brief about what is the stem cells and what is the how the stem cell transplant done. So we know the stem cells. Actually, there are many type of the stem cells like pluripotent stem cells, multipotent stem cells, then the capital precursors, and they are the mature cells. By definition, the pluripotent stem cells, they can transform to the any type of the cells in the body, and the multipotent progenitors or the stem cells, we can say they can transform more than one, but not every type of the cells. So the adult hematopoietic stem cells, from where the blood cells are getting matured, they are like multipotent progenitors, and the stem cells have two specific peculiarities that we are exploiting for doing the stem cell transplant. And which are these? The first one is the self-renewal. They are getting renewal their own cells with the help of the transcription factors. And the another ability is they have propensity to differentiate into the mature cells. It means this, if you see these slides from the hematopoietic stem cells, then the common myeloid progenitors, from there actually the different type of the blood cells like RBC, megakaryocytes, mast cells, eosinophils, neutrophils are they getting the mature, and that's why we are doing the stem cell transplant. Now, how the stem cell transplant differs from the other organ transplant? So if you see here, so these are the patient part and this is the donor part. So when you are doing the kidney transplants, you are transferring the kidney from donor to the patients. When you are doing the liver transplant, you are transferring a liver to the patients. Similarly, in the heart and the cornea transplants, you are transferring the well-formed organ to the patients. And transplant by definition itself says that when you are taking out the organ or the tissue from one body and you are implanting into the other body. So when I say that you are transferring the form or very well formed organ to the patients. When we are transferring the RBC, WBC platelet to the patients, then do you think that called as a transplant? No, that is called as a transfusion. Why? Because this RBC, whatever when you are transfusing, they are maximum they will be in the patient's body for the 100 days, and after that you have to replace again the RBCs. So what we do in the stem cell transplant, to get the mature blood, we are transferring the stem cells from donor to the patients, and that stem cells becoming mature to the RBC, WBC platelet, and that is a stem cell transplant. So you see the difference here. To get the RBC, WBC platelet or the other blood cells, we are transferring the stem cells, not the well-formed organ. The second thing, everybody believe that the transplant is means surgery only. So the kidney transplant, yes, we can say that that is a surgical procedure, because you need to stitch the kidney. Clear. Similarly, you need to stitch the liver cells. Similarly, you need to stitch the heart. But do you think we can stitch the blood cells? No, we cannot stitch the blood cells. So the blood cell, the stem cell transplant is not the surgical transplant, but we can say it's the medical transplant, because similarly, like the blood transfusions, we have to infuse the stem cells through the vein. So again, I'm repeating my sentence. The stem cell transplant, we can say it's the medical transplant rather than the surgical transplant. Now, if you see the type of the transplant, so I told that the transplant means we are transferring from one body to another body. So depending on who is the donor of the stem cells, we divide the transplant in the two parts. That is, autologous stem cell transplant means your own stem cells you are infusing again in your own body. So that is known as autologous. When we are taking the stem cells from another part of the another person, that is called as a allogenic stem cell transplant. Now the allogenic stem cell transplant, once we are saying that there is a donor, actually it means either that will be the related donor or that will be the unrelated donor. Now what is the relation? It means it may be the donor can maybe my brother, my sister, or my parents, or my son. And the unrelated means he can be any of the persons that living in the world. Again, the transplant is divided into the whether it is a match or haploidentical. Now, based on what? So that is in the HLA. So the stem cell, the blood transfusion we are giving to the similar group, while the transplants we are doing when the HLA is matched, at least 50% match, and that is known as a haploidentical. Now, what is the HLA and how the report is looks? So this is the report. The HLA reports, we can say BC, this is a class 1 antigen. Then the DRB1, DQ1, that is a class 2 antigen. And for each location, there are two allele. This is allele1, allele2. Similarly, from other locations also there are two allele. Here you can see this is the 100% match donor. It means these numbers are getting the match. You see here A320111, A3201, A313112, 3112. So for each locus and allele, they are getting match. When that is a 100% match, we can see that is a 100% match and 10 by 10 donor. And when we are selecting as a donor for this person, we can say that that is a match, and depending on the related match related allogenic stem cell transplant. Similarly, if the patients are matching with the donor only the 50% match, this red line, then that is known as a haploidentical stem cell transplant. Obviously, if the 100% match, then it is a better than the haplo. But nowadays, the results are getting better with the 50% match also. And in the malignancy, it's very well proven that like myeloid malignancy, they are non-inferior to the match-related transplant. Now, why that was needed actually? Because we have a chances of getting matched with our own brother is only 25%. It means suppose if I will not match with my brother, then who will be my donor actually? So, but in 75% cases, we are matching at least 50% matching with the brother, sister, or the parents. So that can be, they can be our donor. And that is the beauty of the haploidentical stem cell transplant. Now, from where we are getting the stem cells from the body? Suppose if we are getting the stem cells from the bone marrow, then that is known as a bone marrow stem cell transplant. Suppose if you are getting the stem cells through the peripheral blood, actually, this is the, if you can see, this is the IJV line dialysis port, and from there we are getting the stem cells with the help of this machine, and this is the apheresis machine, then that is known as a peripheral blood stem cell transplant. If we are getting the stem cells through the cord blood, then that is known as a cord blood stem cell transplant. Now, each this source actually has a distinct advantage as well. Usually, we are using the bone marrow stem cell transplant, bone marrow stem cell for doing the transplant in the benign disease. And for the malignant disease, we always use the peripheral blood disease because to exploit the graft versus leukemia effect that we will discuss in the later. And the cord blood stem cell transplant initially that was discovered because we were not getting the enough donor, and the cord blood stem cell transplant with mismatched HLA also you can do. That was an advantage for that cord blood stem cell transplant. Nowadays, but after discovery the haploidentical transplant as well as the success rate, because of the good success rate of the haploidentical stem cell transplant, cord blood stem cell transplant is decreasing. Now, what we do in the autologous stem cell transplant? So first, we will mobilize the stem cells with the help of the GCSF, that growth factor in the blood. Then we will do the apheresis and we will harvest the stem cells. Here, the stem cells we harvest. And after the harvesting stem cells, we are giving some chemotherapy to ablate the hematopoiesis of the patient. And that is known as a conditioning regimen. It means, suppose if I will not give the stem cells, then his blood counts will never recover, because I am telling the ablate. It means totally finish. And after giving the conditioning regimen, I will infuse the stem cells, and from that stem cells, the count is recovering, and usually after 10 to 12 days, the WBCs and platelet counts recover. Now, I will just show you one report actually, and that will help you in understanding that how the count is recovering. You can see this slide also. Hello. So if you see here, so after doing the transplant, after giving the conditioning, you can see the WBC is gradually decreasing, the 140, 60, 50, 30, 20, and that usually goes to the 20. And during these periods, we have to maintain very stringent criteria to prevent the infections, as well as the platelet count is similarly low, and we have to infuse the platelet also, and slowly the count will recover to the normal. So that is the stem cell transplant and the engraftment. Sorry for the slide. Hello.
Yeah, we are not able to see the screen. I think screen sharing has some issue. We are able to see your full screen now. You can stop the screen sharing and once again go back to the screen sharing.
Okay, sir.
Yeah, now redo the screen sharing and then click on the presentation in the background that you have. There will be multiple tabs on your screen when you do screen sharing. One of the tabs will show you your presentation. I think he has logged out. Yeah, he's back again. Yes, please go ahead, Dr. Silas. Now we are able to see. You have to unmute. Dr. Silas, you are muted.
After the
Yes.
conditioning regimen, essentially the WBC and the platelet goes to the 0, and after this, once we infuse the stem cells, from there, slowly the hematopoiesis will be regained. And usually after the 10 to 12 days, the WBC counts and the platelet counts will be in that range, in the safe range, and discharge the patients. So the during autologous stem cell transplant, we can see that divides into 3: the stem cell mobilizations, then the conditioning regimen, and the stem cells infusion with the neutropenic care. Similarly, in the allogenic stem cell transplant, as I said earlier, in allogenic stem cell transplant, there will be the uh, donor who is donating the stem cells. And the patients, we are first inserting the Hickman catheter. After that, we give the conditioning regimen, then the stem cells infusions. And once the stem cells infusion made, the hematopoiesis will regain from the infused stem cells. Now, these stem cells is actually not his own stem cells. It means they are the foreign cells, and that can give the reaction to the patient's body, and that is known as a graft versus host disease. So, to prevent the graft versus disease, we are starting the medicines from the day -2, and till, depending on the disease, actually, like in the malignancy, we are giving the GVHD prophylaxis for the 3 months, and for the benign disease, we are giving the GVHD prophylaxis, that is immunosuppressive treatment, that is almost for 1 year. Now, another thing needs to be understood in stem cells. When we are infusing the stem cell infusion, that day is considered as a day 0, and before all the days, they are considered in the minus. So suppose these patients, if you can see, the day -17, we have started the conditioning regimen. It means the 17 days before to the stem cells infusion. And after the stem cells infusion, whatever the day is getting, they are labeled as a plus actually. Means +1, +2, +3. If suppose I say the plus 30 days, it means he is a post-transplant after the 30 days. Now, in allogenic stem cell transplant, the blood cells are formed. Means we can see in the CBC, the neutrophil, as well as the platelet. But how can we decide whether that is a donor's blood actually or the patient's blood? So to know that whether they are from the donors or the patients, we are doing the chimerism test. And the chimerism test we are doing with the various method like the molecular method, cytogenetic method, or even we can use the blood group. And the other interesting part of the stem cell transplant is the suppose patient is the blood group is A, but the donor blood group is B. Then after the successful stem cell transplant, the patient's blood group is going to change to the B, because the hematopoiesis is derived from the donor. And these are the various side effects depending on the medicines we use during the conditioning regimen. That can be the fever, anaphylaxis, the convulsion, as well as the abdominal pain and the diarrhea. And this is the day-wise the complications that can happen after the transplant. And the most crucial period is the first 15 days, because essentially after 4 to 5 days, your counts will be, the WBC counts will be the 0, means you have highest chances of the infection. Your platelet counts is also maybe less than 10,000. And the medicines we are using during the transplant that can increase your blood pressure. So you have highest chances of the intrarenal bleed. And during this period, the chances of side effects, those medicines we have given before the infusion, that will be the highest. And once the count is recovered, you are safe, is relatively safe from the infection. But again, we need to remember that immunity is going to be low for at least 1 year. In fact, how much immunity is going to be finished means if you have, means we need to again revaccinate the patients, because whatever the vaccination he has received in his childhood, that effect is going to be finished. And after the 30 days, once the cell formed from the graft, actually that can react to the body, and if it's manifestation like the diarrhea, jaundice, or the other skin disease, then we can label as a graft versus host disease. And if it is grade 1, we can easily control. But if it is grade 4 and that steroid resistant, then the mortality is almost 50%. If this GVHD reaction is happen before the 100 days, then it is known as acute GVHD. If this GVHD happens after the 100 days, then it is a chronic GVHD. The chronic GVHD essentially affects all kind of the organ. And the another the long-term complications that we need to remember that can be the infertility also, that depending on the medicine used during the transplant. And the success rate of the allogenic transplant and autologous transplant is depending on the disease base. Like the allogenic stem cell transplant in thalassemia, I said earlier, less than, when we are doing the transplant less than 7 years of the age, then the success rate is 90%. Similarly, when I do the allogenic stem cell transplant in the myelodysplastic syndrome, then the success rate is 40 to 50%. Now, what is the indication of the autologous and allogenic stem cell transplant? So the autologous stem cell transplant is the multiple myeloma, relapsed Hodgkin's lymphoma, relapsed non-Hodgkin's lymphoma, amyloidosis, pediatric relapsed solid tumors, and relapsed APML. These are the malignant indications. And in the allogenic, we do in both, that is indicated is also in both malignant as well as non-malignant disorder. Non-malignant disorder like thalassemia, sickle cell disease, immunodeficiency disorder, storage disorder, and congenital HLS. In the malignancy like AML, ALL, myelodysplastic syndrome. And that also the helps in bone marrow failure syndrome, like congenital bone marrow failure syndrome, or acquired the acquired bone marrow failure syndrome that we can say that aplastic anemia. So this is the overview of the autologous and allogenic stem cell transplant. And our center is a member of Indian Society for Blood and Marrow Transplantations. And our number is 191. It means we are submitting our data to the Indian Society for Blood and Marrow Transplantation, and they have accepted as a member after uh, 5 transplantation done in our center, and they have seen our data is also authenticate. Is it's very authentic, so they have accepted as a member. Now I will tell about my journey at the KCHRC. So I was working in the Ahmedabad, and one day I got the message from the WhatsApp that we are going to start the stem cell transplant facility. If you are interested, then you can join. So after that, I told just initially I'll come as a once in a week, and I was traveling from Ahmedabad to Baroda, in fact to the Goraj actually every Monday. And slowly I worked as a 6 months actually, and I've seen I trained the staffs in actually in the managing the leukemia, lymphoma, and slowly I gained the confidence. And after that, I told the management. The management has also given the permission, even though the stem cell transplant unit that time was not ready. I convinced them that we can do the autologous stem cell transplant in the simple isolation room. Just that needs to be clean, and the surface needs to be properly disinfected by the disinfectant solution. And the first transplant we have done in the relapsed Hodgkin's lymphoma, that was a 17 years old boy, and the transplant date was 9th May 2019. So initially, I was very confident that we will easily do the transplant. But after the stem cell infusion, within 3 to 4 days, the patients went into the septic shock. But fortunately, he recovered from the septic shock, and actually he discharged. He discharged. Hello. He's discharged actually, and presently he's a student of IT. And yesterday only I called him actually. He's in Dehradun. He's giving his exam of the first year. So from this actually transplant, I learned a few things, like the training of the nurses and other staff is required. The second thing is documentation. The third thing is communication. Fourth thing is audit. And the fifth most important thing that actually we discussed and we came up that we should utilize the workshop. Now, why the training of the nurses? Because actually during the transplant, when I audited this patient, how it goes to the septic shock actually, because everything was fine. So one of my staff told me that one day he was he had a second, like he didn't tell the chins actually, and that was not informed to them. And that time the count was essentially I think 300, and after that, after 1 hour or 2 hours, he got the fever, and that time we started the antibiotics. It means we were the 2 hours late, and the patient once in the transplant, that serious response came, and after that it was very difficult to manage. So here actually our friend means my staff that whatever that happens, you just inform me. Even in the night 2 o'clock, 3 o'clock, if patients having the chills, you are supposed to inform me. The second thing we discussed that the signs, earliest signs of sepsis is tachycardia. So we are starting the antibiotics whenever there is a tachycardia, and that is an unexplained tachycardia. Even there is no fever actually, because many times we don't get the fever, or we got the fever once after the 1 hour of the tachycardia. And by using this policy, you will not believe, the out of 50 transplants, the 2 patients we didn't use the paracetamol. It means they don't have fever actually. So that was like means very good nursing care actually. The second thing I can say that slowly after each transplantation we are discussing, and you can see my slide actually. They are informing each and everything to me, and you see here. So the first, this is the WhatsApp screenshot. They are writing everything like evening out. They are informing the evening intake output, the patient-wise patients, and now they know. So they are supposed to inform the after how many days of the transplant. It means that this is the day plus 9. They are informing how much they have taken the orally IV intake output, and the most important thing part, if you see here, they are writing the admission weight as well as the particular that morning weight and the evening weight. And you see here, they have written the wrong spelling, but what they are supposed to inform, they are informing. And the importance of this message and the information you can see here. So this patient admission weight was 56 kg, and this is the 2 days before weight. That morning weight was 59.8 kg and the evening weight was 60.4 kg. If suppose if they will inform me the weight on that morning and that evening, so I will interpret it as there is no change. But when I will see this evening weight in comparison to the admission weight, then I will see there is a gain of the 4 kg. So even though he is having the 10 times loose stools, I have given the lessons. Why this is important? Because we have given the such medicines in that the chances of the complication of veno-occlusive disease is high. In the veno-occlusive disease, he will have the ascites, edema, and the liver failure actually in subsequently if it is not getting control. And once there is a accumulation of the fluid, he can have the breathlessness also. Similarly, you will see this message. Then they have clearly documented the stage 1 and stage 2 BP, stage 1 and stage 2 BP, stage 1 and stage 2 BP for 3 patients, because we have a 3 pediatric patients that time. It means they understood that the blood pressure monitoring in the adult as well as the pediatric is the different. And the 120/80 is not normal the BP, but the normal BP is according to the age. It means suppose this patient's BP is more than 110, immediately they will inform me that the BP is crossing the line, and we will give the antihypertensive medicine depending on his platelet count, depending on the drug level in this. And the third, you can see the photograph. We are writing for each and every patient in the file the height and weight, his the blood group, and his the stage 1 and stage 2 BP if it is a pediatric patient. So this is how we are using the WhatsApp. And so far our discussion with the nurses, and the nurses has gained this kind of the training, and they have achieved the level that they are assessing the patients is very well. In fact, I can say we don't have the medical officers in the BMT unit, because I rely the most on the senior nurses rather than the new medical officers, because they know that what's happening actually. And this is the purpose that I didn't keep the medical officer in the BMT units throughout the day. Suppose some complications get happen, if I could not reach, then I'll say the medical officer to visit to see the patients and inform me. The second thing is the documentation. So you can see here, so we can document like vitals by the time, and everything is getting documented: temperature, pulse, respiratory, and along with the nurse's name. Because why it is important, the similarly we are documenting the other things also. And why it is important, because suppose something goes wrong, and when we are doing the audit actually, then this nurse is supposed to answer that why they have not informed or why they have informed actually. So that will help us in improvising our service towards the patients for the in the upcoming BMTs. The second thing, the third thing is communications. So now the communications, and here again, if you see we have used utilized the WhatsApp actually. So whatever happened, you just inform to the consultant. So suppose the line has done, after the post line X-rays, they will take the photograph and they will WhatsApp. While doing the Hickman, the second photograph is a Hickman dressing. Anything unusual they notice, they took the photograph and they will send it to me. And depending on that, immediately we are taking actions, whether what is to be done with this line. The third thing you can, here the third and fourth photograph, you can see here, that is a urine color. The after stem cell infusion, the patients had hematuria actually. So immediately they message me, and I have increased the hydrations. And the same day night, actually, they again they send the photograph, and that is showing the clearing of the blood actually from the urine. So depending on that, we are titrating the hydration. And these are the just photograph of the photograph only. We are usually sending the WhatsApp video also, like CT scan. Suppose the urgent CT scan is done, CT brain, then one staff will go to the radiology unit, and from the computer he he will shoot the video, and that video immediately he will send to the WhatsApp. So even the night 2 o'clock also, I can see the images of the CT scan of my patient. And if I have doubts, immediately I'll send to the radiologist and they will report us. So from the first transplant, we learned so many things actually. And in fact, every transplant we are learning something and that we are implementing. So this is the first pediatric autologous stem cell transplant. And you see here, this is a 7-year-old boy, and he stayed with his grandfather actually. And surprisingly, means that was very, very surprised for me that they were staying in the farm actually. They don't have a house actually, and we have done the transplant. And that can only happen in the Kailash Cancer Hospital actually. And the our nursing staff actually, they have trained them very well, so they are getting the all type of the aseptic precautions, and we have successfully discharged this patient also from the transplant unit. Unfortunately, he relapsed after 2 years, and after that he did not opt for the further treatment, and he died. The third one means essential, that is a 6th transplant, but that was a first allogenic stem cell transplant. Now, all the transplant centers, when you're starting the transplantation program, they do usually autologous stem cell transplant, and after that the allogenic. Similarly, we have also done the same thing. The first 5 we have done the autologous. In that also, first 4 is like adolescent to adult. The 5th one is pediatric, and the 6th one we have done the allogenic, and that is a match-related allogenic stem cell transplant. And this is the case of the relapse AML. He is still alive, but unfortunately, he is having the extramedullary relapse. And again, this transplant, I have learned actually, the cost can be minimized if you are using the judicial, the way the medicines. Like the minimum cost of this transplant is outside is 14 lakh rupees, and we have done in only 5 lakh rupees. So now how it is done, that we can discuss one-to-one way actually, because everything I cannot explain through this presentation, but that was the really the learning point, because in my life actually I have seen the first allogenic stem cell transplant getting done in 5 lakh rupees. Now this is the second allogenic stem cell transplant and the first pediatric stem cell transplant, and the case was the thalassemia major. The transplant date, if you see here, so December 2019, and almost like 2.5 years now, he's alive and he's planning for his school. So you can see here in the first photograph that he is enjoying during the transplant. Like it means the credit goes to the nursing staff. They will not feel them bored actually during transplant. And why I'm saying this, the credit, because during the transplant, this child has stayed almost 40 days in only one room and with this one bed. We are not allowing them to go to the outside. So this is really, really very difficult situation. That we are improving, and our number is also increasing. So almost 13 transplants we have discussed with my, like we have discussed like among the BMT team, like the nursing staff, BMT coordinator, management, and then now we are ready for the haploidentical stem cell transplant, because the haploidentical stem cell transplant is considered as one of the toughest transplant. And we have done, means we have taken the first transplant in the March 2020, and that was our 14th transplant. And if you see here, so we have given the TBI also. The TBI is the kind of radiation in that the entire body is get irradiated, and that was the first time in the Gujarat. The TBI was like single fraction in the one day only, and the patients got also discharged. This patient also alive today. And the most important part during the last 2 transplant, the first allogenic stem cell transplant that was done in the Ma Amritam Yojana of the Gujarat. And that is the advantage of being in Gujarat also, because during the Ayushman, means in the Ayushman Yojana, the Gujarat only supporting the stem cell transplant compared to the other state. Similarly, this haploidentical stem cell transplant also done under the Ma Amritam Yojana. that is also the first time in the Gujarat actually. And that was shocking for me because I discussed with the management that hepatoidentical stem cell transplant, the cost is approximately 20 lakh rupees. And the patient doesn't have the finance, but he is having the Ayushman card. And some basic calculations I've done, and I told the management if there is no complications, then probably will come out with that amount only. And luckily, there was no complication during the transplant. And again, the cost is also minimum, and that was again shocking for me. And as I have done the transplant in the KCHRC, I got the confidence that uh, uh, regarding the success rate as well as the financial management. And during this transplant, actually, means after that, this first haploidentical transplant, I have done the second haploidentical stem cell transplant, and unfortunately, that get complicated, and the cost is actually increased to the almost 15 lakh rupees. But that day, actually, I remember the word of Dr. Vikram Patel sir and the Dr. Kantaya sir, that nothing is free here, but money is never consideration. So that was like the great help to me also, as well as to my patients. And luckily, the patients also discharged. But unfortunately, after 7 months, he died actually in the COVID. And again, during the second haploidentical stem cell during this transplant, we have used the TBI, that is a multiple fraction. It means the 4 days, the morning and evening, we are irradiating the patient's body, and that was also first in Gujarat. And by this first in Gujarat, that credit doesn't goes to me actually, that goes to our radiation department, the radiation oncologists and physicists who accepted this challenge actually. And after the basic calculation, they told no, they can do the confidently, because the first thing whenever you are doing actually, that is a little bit complicated. Now we are frequently doing the TBI, and why the TBI is important, because the TBI has like it is proven that is the better conditioning regimen in the ALL. Now, again, as we are learning and we are getting the confidence about doing the transplant in our unit, the one more challenge has come to us. That was in January 2020 or December 2021. The one patient came with a myelodysplastic syndrome, a young boy, around 35, 36 years. And he doesn't have match with his sister, that is 0%. And his parents are very old, actually, 70 years, with so many comorbidities. Child he's having. So he told that I have only one daughter. So when it's okay, the transplantation, we need the stem cells. And to get the stem cells, if she's 50% match, then I think probably we can do the transplant. So he also accepted these things, and we have sent the HLA. And luckily, that HLA was 50% matched to his father. It means the daughter is having matched to the father. Usually, we'll see the father is always goes to the child actually, but here the reverse is there. The daughter gives the stem cell to the father. The second challenge was here actually the weight of the donor, because we cannot harvest so many cells actually, and that depending on the donor's weight and the donor patient weight ratio. So patient is almost 80 kg and the donor is roughly around 15 to 20 kg. So again, the first day we did the harvest and that was not inadequate stem cells. And the second day I explained that the plates are for medicines. So that are recommended use during the autologous stem cell transplant, but that is in case-to-case based use in the normal healthy donor. Again, after the discussion with the scientific discussion, they have accepted and we have given the plates support. In the second day, we got the adequate stem cells, and that was our first transplant, like pediatric to the daughter to father. So what we have done, we have not started the conditioning regimen, but we have harvested, we have cryopreserved our stem cells. And once we are confident that we have adequate stem cells, we have started the conditioning regimen, essentially the transplant. And here the credit goes to our blood bank team, who also accepted this as a challenge, and You can see here, this is the Jayesh Bhai. He's our senior technicians in the blood bank. The doctor's photograph is not here actually. He's a Dr. Arpit Patel, and the successful stem cell harvest done by their team. And subsequently we did the transplant. And these patients also get discharged, and presently is almost 5 months, or 4 to 5 months, and he's doing work from home. So again, this is the happy ending. After that, here during this transplant, we have done one inhuman thing actually. What we have done actually, we have not asked for the PAC actually, that's pre-anesthetic fitness, and we grabbed the child actually, and we put forcefully the dialysis port actually. So the donor was crying actually, but I was not having that option actually, other than because the donor has a food actually, so I cannot give the anesthesia in the afternoon. I need to harvest the stem cells. But luckily, we have put the line also. But here we learned actually that for pediatric patients, even though they have given the agreement that they will cooperate during the line insertion, but always ask for the anesthesia. So the second child also came like that. Here, this transplant, the donor was donating to his brother only, but again the weight difference was too high actually, and we have to do the peripheral blood stem cell harvest because he was also having the disease like that class 3, and here we have done we have corrected the mistake actually. We have done the PAC fitness, and we have done this harvest under the anesthesia. And for that actually everybody has like very well planned actually, because we have informed the engineer there is a breakdown in the machine, then what, and that was like that engineers came to the Baroda even prior to the harvest. The anesthetic team actually, because the harvest usually lasts for 4 to 5 hours, so they have managed.
I think there is a problem with his internet connection. Let us wait for him to rejoin. Yeah. Yes, Dr. Silas, please unmute. Dr. Silas, can you hear me? So please unmute. Please unmute. Please unmute. We can wind up the session without the remaining presentation. Please unmute so that we can hear. No, you are not audible because you are muted. You have to click on the speaker. On the left corner of your screen, no, you will be able to mute and unmute with clicking on the mic icon.
Yeah.
Yeah. So,
so this is the last slide.
Finish with your presentation, or you can wind up without.
Yes, one slide on. One slide only, sir.
Because your connectivity is very unstable, it seems, because your voice is cracking.
Yeah.
So what we can do is that we can take a few questions, because you may not restart the presentation. Do not share your screen now, because we already 5 minutes left. What I suggest is that we take up some questions, and I noticed that in the chat box, there is one very relevant question from Dr. Deepa. She's an obstetrician, and she is asking about stem cell banking. It's a very controversial kind of a issue where a lot of banks are offering these services of stem cell preservation at a very high cost, and there are issues regarding real utility of this so-called banking of the stem cells. So do you have any comments on that?
Yes, sir. Yeah. In fact, I wanted to convey that message also. Can you hear me, sir, now?
Yes,
Hello?
we can hear you. We can hear you. Please go ahead.
Okay. Sir. So, see, I want to answer like that. I have one daughter, but I have not stored my own stem cell, my daughter's stem cells, even though I am the stem cell transplant physician. Now I'll explain why. So when you are preserving the stem cells, either the stem cells will help to that child or the another patients. Am I right? Suppose if you are going to use the own stem cells for his own body, but if he's getting the disorder, that is the stem cell related disorder, then I cannot use that stem cell for his own. Correct? Now the second scenario, I am going to use that stem cells to the another person. But in India, there is no concept of the public cord banking. Whatever we have presently, it is a private cord banking. It means we are spending our own money for reservations of the stem cells, our own child. Suppose if you have two child, the first child having the problem and the second child I have stored the stem cells. And if the first child needs the stem cell transplant, then I can take out the stem cells from his body. I don't need his cord blood cells because he is alive. He is with me only. So I can do the harvest from the bone marrow as well as the peripheral blood after some age and the adequate weight of that donor. The second scenario is here. Suppose my first child is around 14 to 15 years, and the second child that I stored the stem cells is around 2 years. So the stem cells, what is derived from the cord blood, the dose of the stem cells is less. So I cannot do the transplant from the one cord. So I need the multiple cords. Now to get the multiple cords, I need to have the HLMH, like the same kind of HLA from the another cord, and their parents are supposed to give the permission to use that cord. You understand this one? So suppose if their parent doesn't, the other parent doesn't give the permissions, so I will not have the adequate stem cell dose from the single cord. That's why I use the word the public cord banking. Yes, if the concept of the public cord banking starts in our country, then that will help. But in that case, your stem cells without your permissions can be given to the other person also. So in that case only we can collect the multiple stem cells from the multiple cords and we can infuse to the patients. Then only that will help. And another thing, when the cord blood stem cell transplant was gaining the publicity, that time the success rate of the haploidentical stem cell was low. Nowadays, the haploidentical stem cell transplant, the success rate is also increasing, and almost 75 to 90% cases you will have the 50% match with either mother, either father, or either the sibling, and we can do the stem cell transplant. And with the increasing the success of the haploidentical stem cell transplant, the unrelated donor stem cell transplant also decreasing. So in my recommendations, I usually do not suggest to store the stem cells, but again, that is the individual choice.
Thank you, Dr. Silas. That was really very wonderful journey that you narrated. Something so important is happening nearby us. It's very heartening to know that now we can have our patients DMT done at a lower cost also, with the help of your institute as well as the help of government, which is bringing out a lot of schemes for such poor patients. So thank you, sir, very much for sharing your experiences, and we all wish you all the best for your future endeavors in this direction. So thank you. So we end the meeting here. It's already 9 o'clock. So we meet again